Is my volume okay?
Your volume's good.
Because I'm just talking to my computer. I didn't put my earphones in.
Okay. Yeah, your volume's good. Okay. I'll bring you up in just a sec.
Sure. Got a few people to admit. Somebody said this is a bad link.
Well, if they said it's a bad link in here, they made it.
Yeah,
So
I know.
I'm assuming that it's a good link. All right, I'm going to get you started.
Okay, get down to slideshow. Okay, good morning. Welcome to the, I guess this is month 11 of the 2020 COVID and the changes in PCEP being all online and for a brief section. Today we're going to do, this is our annual refresher, mostly for cardiac arrest, mostly for basic life support, but I have, because we do talk about pit crew, I have included the basic information and outline of management of cardiac arrest. We will do more cardiac arrest specific management later on in the year. Now, the other inclusion today will be some changes in protocol, most of which are minor, one of which might be considered major, but we'll get that at the very end. All right. See if we can get Dan in. Okay, as you know, the American Heart Association every year has a emergency cardiac care and resuscitation updates. Originally, back in the 70s, when I started doing ACLS, that was a 10-year redo, and of course, lots of things happened in that 10-year period, and so we were always doing sort of cutting edge things before the American Heart Association caught up. Then in the 90s, they went to doing upgrades every 5 years, and then 5 years ago they decided to do upgrades every year because they were using primarily an online format so that they could, an electronic format so they could update things really rapidly. So the Heart Association caught up to, most of the EMS units because we've been doing an online format to keep our protocols active for a long time. Now, in the 2020 summary, which just happened in the conference was in November, they noted that in 2015, they had 350,000 adults had non-traumatic out-of-hospital cardiac arrest seen by EMS. Less than 40% of those received layperson CPR. Less than 12% had an AED. And after, I've got to get him out of got too many people I can't see there we go. After initial improvements, and one of the initial improvements, I think, frankly, was that we were studying with the ROC studies. We were really studying out of hospital cardiac arrest, and there's a thing called the Hawthorne effect that when you study something, it gets better even if you aren't making any significant changes in medication or in anything else. It's just that things that get studied everybody pays more attention to it and they do a better job. So we sort of peaked and plateaued in our survival from out of hospital cardiac arrest about 2012 to 2014. And we'll see, I think you'll see that um, um, reflected in the, we're going to show some walk cares data for last year and previous years. And so we can see that we sort of plateaued and then we're sort of sneaking up again, at least in Washington and Clark County. All right, the major changes, key issues and major changes in the 2020 Heart Association guidelines are not very exciting, and they're not significant. We haven't had a magic bullet popped up. They combined the ALS and BLS changes in the 2020 guidelines because they used to print them separately, and it doesn't make any sense because we work as a team. They did enhance the algorithms they've improved them so they're easy to remember guides. And I'll show you a couple of them toward the end. Early lay CPR has been reemphasized. And here's the big one: reemphasis on early epinephrine administration in non-shockable rhythm. And in shockable rhythms, we do early defib, then epinephrine. Use of real-time feedback is recommended, and there's a lot of devices out there that do that. We have some audio feedback, but we don't use pucks on the chest to show CPR. We rely primarily on the training and quality of our EMT CPR. Continuous measuring of blood pressure and ETCO, ETCO2 during resuscitation can be used to improve quality. Now we do that, of course, and sometimes we're confused by our ETCO2 measures, particularly during asystolic and PEA arrests. They do not recommend routine use of double sequential defibrillation, much to the chagrin of Multnomah County. Pediatric issues. If you have a pediatric patient with a pulse but absent or inadequate respirations, they're wanting a breath every 2 to 3 seconds or 20 to 30 breaths per minute. Based on the size of the child, basically. So an older, an 8-year-old child would use less breaths, maybe the 20 breaths per minute than a 1-year-old child. During CPR in pediatric with an iGel or an ETT, ventilation is targeted at 1 breath every 2 to 3 seconds. Once again, accounting for the age and clinical condition of the child. So the breaths have increased a bit. Also, they reiterated that cuffed ETs tubes are safe for children, and also that routine cric pressure during intubation is not recommended, just like it's not routine cric is not recommended in adults either. But they added this to the peds now. Peds epinephrine, if you're going to do epinephrine, you should do that. Start it within 5 minutes of the start of chest compression. So early epinephrine, especially in an asystole or a PEA. We have embraced pit crew CPR in our company. The principles of high performance CPR, the principles of pit crew are EMTs own the CPR. So what that means is the most important person on that chest at that point is on that patient is our EMTs giving the giving compressions, and then followed by a layered approach to do other adjuncts and medications. Minimize interruptions in CPR at all times. Ensure proper depth of compressions, at least 2 inches. And indeed, they say 2¼ inches. Well, okay. Ensure full chest recoil and decompression. Ensure proper chest compression rate. Chest compression rate, 100 to 120 per minute. 110 is ideal. Big red sign here, rotate compressors every 2 minutes. Hover hands over the chest during shock administration. Be ready to compress as soon as the patient is cleared. We use an I-gel airway with ongoing CPR to start with. Place an IV or an IO with ongoing CPR. And coordinate and teamwork between the EMTs and the EMT paramedic. So, high performance CPR. That hasn't changed. Establish unresponsiveness, shake, shout, all those sort of things. Pulseless and apneic. Begin CPR, one hand in the middle of the chest, etc. Push down hard, at least 2.25 inches fast, 100 to 120 per minute. Now, why do we do good CPR? It's the foundation of resuscitation. High-performance CPR improves the effectiveness of defibrillation. High-performance CPR improves the effectiveness of medication treatments. CPR is compression, airway, breathing. Now, it is not the other way around. Now, the science is pretty clean. The likelihood of return of spontaneous circulation increases significantly with a higher mean compression rate. Now, we didn't quote this because nobody remembers the quotes, but in a hospital study, 75% of patients achieve ROSC with 90 or more chest compressions, compared to only 42% with 72 or fewer chest compressions. You might say, well, so why are we not doing 90? Well, because it's 90 or more. They put that at the lower limit. They still noticed the difference at that point. The sort of transition space was between 72 and 90, but with more than 90, with between 100 and 120, they had even more return of spontaneous circulations, but they set the lower limit at 90. We don't do it. We want to rate it about 110 as an average. And when you do compressions of 120 per minute for 2 minutes, and then you take less than 10-minute pause where you're checking your rhythm, you basically have a net over that 2-minute period. You have a net of 110 per minute. Return of spontaneous circulation is also decreased with too fast a rate. So compression rates above 130 were negatively associated with return of spontaneous circulation. So that's why we want to go, that sweet spot's about 110. Now, better compressions lead to better organ perfusion, which leads to better resuscitation. The greater the depth of compression, up to a point, of course, you don't want to go over 2.25, because then you start to get into the likelihood of more rib fractures and things like that. But in that better compression, that 2 to 2.25 inch compression for the average adult, then you're dealing with increased likelihood of then having a successful return of spontaneous circulation. Compression equals organ perfusion. Decompression is heart perfusion. Compression, you increase intrathoracic pressure, pushing blood from the heart and lungs. So you're increasing the forward output and adding some and contributing to the production of actually a blood pressure. When you decompress, completely come off the chest, you decrease intrathoracic pressure, which pulls blood into the heart and the lungs, and then blood flows into the coronary system during that decompression cycle. So you're not only filling the lungs, but you're filling the coronary arteries. And that's the game here, is we're trying to reperfuse the heart through the coronary arteries. You need an adequate blood pressure in the aorta to cause enough flow, to cause enough difference in pressure between the diastolic pressure. The end diastolic pressure will allow blood to flow into the heart. So there has to be a difference between the aortic pressure and the pressure in the left and right atrium. Now, how about pausing? We do continuous compressions as much as possible. Pausing makes a difference. Longer pauses in chest compression lower the chances of a positive outcome. So the longer the pause preceding the shock or following a shock, the lower the chance of survival. There's a little guide over there showing, and this was in a animal study, but they had if there's only 3 seconds of interrupted CPR, they had literally 100% resuscitation of their subjects, and if they had 15 seconds of pause, there was less than 40% resuscitation. And this is in a controlled setting, so it's even worse in a when you're in a not in an actual clinical setting. Incomplete decompression is inadequate blood volume in the heart and lungs. Yiannopoulos, who is an incredible researcher who's done all the research on extended on using ECMO and immediate going to the cardiac cath lab for refractory VFib with up to 1 hour of a cardiac arrest, has had remarkable improvement in survival. And one of his studies showed that if you only decompress the chest 75%, that doesn't provide sufficient coronary or cerebral pressures to achieve ROSC. I mean, none of his subjects survived if you only had a 75% decompression of the chest. So the answer is just, give complete decompression. Inadequate decompression compromises both coronary and cerebral blood flow. So, and the decompression phase is one of the reasons that the Lucas device may be an ideal device for CPR, because it has an enhanced decompression by that sort of little suction cup plunger, so it actually adequately decompresses the chest. And of course, you dial it in so it has the appropriate 2 to 2.25 inch compression. Inadequate decompression compromises both coronary and cerebral blood flow. So this may contribute to, even if you get ROSC, it may contribute to the ultimate cerebral death from cerebral anoxia of patients. Limited periods of incomplete decompression has a lingering effect, just like long pauses. It takes you, if you pause your compressions, it takes at least 20 compressions to get back to where you started. The same thing happens if you have a long period of incomplete decompression. In other words, if you have a fatiguing compressor who is sort of resting on the chest and doing incomplete compressions, that can have more than just that several seconds of problem. This may compromise cerebral and coronary perfusion for up to a minute or more. Now, this is one of the reasons why we want to rotate compressors so that we don't fatigue. Perfusion, of course, is the mechanism that circulates medication. The better the perfusion, the better the circulation of medication. Good CPR improves the circulation of blood and the circulation of, let's say, epinephrine. Studies have shown that good CPR decreases by about twofold the amount of time required for epinephrine to reach peak concentration in circulating blood. Now, even good CPR is perhaps 25 to 30% of normal perfusion. So bad CPR, being even less, would be in the 15%. This is probably one of the reasons that when you're using an IO, there's an increased time when you're doing CPR, increased time of circulation with CPR of epinephrine and other medications. If you're using a peripheral IO, such as a femoral or a tibial IO, and that because your CPR is just not that effective. So that's why we are now recommending that the IO be a humeral IO if you're in a cardiac arrest, low perfusion kind of situation, or better yet, a upper extremity IV. Now, pit crew. Pit crew is sort of the acme in the CPR world for teamwork. They picked the idea of using the pit crew with the NASCAR kind of slogan because in NASCAR, every person on that crew has a specific assignment. Teamwork is the key. The 3 C's are collaborate, communicate, and coordinate. We have an increased focus on using a team approach. Many interventions performed simultaneously, minimize interruptions and compressions. Clear communication minimizes errors. High performance CPR begins with a foundation of EMT CPR. So that's the building block. Advanced cardiac life support is layered upon that to enhance it and enable it. The approach requires teamwork. Pit crew approach is simply an organizational method for managing resuscitation. Predetermined assigned position and responsibilities. The approach has to be rehearsed and practiced on a regular basis. Ideally, you should be practicing your CPR and ACLS cardiac arrest protocol at least once a month as a team. The number one priority is maintaining high quality CPR with minimal interruptions and no interruptions longer than 10 seconds. I'd actually like to see it about 5 seconds. Now, when you don't have enough resources, so in the smaller agencies or when BLS arrives several minutes before another crew, or when sometimes the crew that arrives is only a 2-person crew and you have and that's all you get, then the pit crew approach needs to be adapted. How many people are necessary for a pit crew? Well, it's, somebody once said you have to fight the war with the army you're given. That's kind of the way it is. But and I can't tell you the exact things yet, but we're publishing a paper. We have a paper out for publication. By we, I say some of the old ALPS researchers, and one of the papers is on the ideal number of persons at the scene of a cardiac arrest, and it looks like you get more chances at ROSC when you have 7 or more people present. Now, this is a retrograde study looking at data from the ALPS program, and this was before Lucas devices, etc. So the pit crew can certainly be modified. I know that North Country has had good success by augmenting its small crew size by putting a Lucas machine on people early. That's one of the options, but at the present time, we'd still like to see a pit crew. An ideal pit crew is about 7, at least 7 people. Now, pit crew can only be done when you get the cardiac arrest victim moved out of the bathroom and into an area where you can actually do resuscitation, and that may, depending on the situation, may even require that you do what you can do until you get the patient into the rig or into an area where you have enough to work. If you have limited resources, basic CPR and defibrillation are still the first priority. All our other activities are accomplished as additional resources arrive. I know in the past we've even employed family members to be compressors. Incident command principles are followed. Now, sort of the ideal setup, and this varies then by the number of crews you have. The first arriving paramedic is the team leader for resuscitation. First arriving company officer is, this is military, sort of the incident command stuff. Fast attack incident commander responsible for non-medical management of scene, safety, and liaison, while assisting with resuscitation. The second, if there is a second arriving company officer, that is the strategic incident commander who has non-medical management of the scene from the tactical incident command and remains in a strategic position, uninvolved in the resuscitation if possible, and if possible means if there's enough other people there. And there probably should be if that's the second company. Position 1 is the compressor. Determines cardiac arrest, expose the chest, begin compressions, and announce when at compression 180, 190, and 200, because we are not going to come off the chest until we're ready to view. And at that time, at the 180, 190, and 200 under our current current training, the person managing the defibrillator will charge the defibrillator at that point, immediately determine, so prior to coming off the chest, and then immediately determine what is the rhythm, and if it's shockable, to deliver a shock. If not, to dump the charge. Position 2 is the life pack operator turns the life pack on to timestamp the beginning of CPR, start the metronome, apply defibrillation patches, and I prefer AP placement if possible. And if you've used conventional placement, that if you've had 3 shocks so that they are in refractory VFib, then I would ask you, if possible, to change that patch placement to an AP. Pit crew number 2, position 2, also monitors compression quality, speed, and time intervals, charges the monitor at compression 190, interrupt rhythm and shock if indicated after compression 200. Alternate doing compressions if needed until additional resources. So position 1 and 2 can change around. Position 3 is airway. Oxygen via nasal cannula at 10 liters, then with BVM ventilation after the first defibrillation. Now, we would like that an I-gel inserted after the first or second defibrillation, depending on the size of your crew and how quickly you can do that, and provide ventilations on the upstroke, continuous CPR, no stopping for ventilations, attach an EtCO2 monitor, suction as needed. Intubation should be done if required for airway control and if it doesn't interfere with compressions. And that's now in the time of COVID, we are doing less and less intubation. We're staying with our I-gels. The I-gels, we're very familiar with it. They're working very well. They may not be 100%, but they're pretty good. Now, position 4 alternates compression, is the compressor. So alternate compression so that they will then rotate between position 1 and position 4. Position 5 would be handling IV and IO meds. An IV TKO with balanced salt solution. Above the diaphragm is preferred, and preferred would be arm vein, antecubital, humeral IO number 2, except in pediatric. Least preferred would be a tibial IO or a femoral IO in pediatric out-of-hospital cardiac arrest. And then as soon as possible to get an antecubital vein in, IV in. Now, IO insertion could be done first, particularly in a humeral IO, if IV success is unlikely for whatever reason. That's a paramedic determination. And then position 5, the IV-IO would administer any required medication. Position 6 is strategic, incident command, safety, liaison with family and other agencies, develop an egress plan. Position 7 and 8, backup, assigned as needed. So we've got down to 7 people. So 7 and 8 people. Now that would include, that's probably 2 companies, and at least in Vancouver and Fire District 6, that's two companies, and an ambulance crew. This is just a schematic of sort of how you might position people and how you would practice having people in their position. And so you have access to the patient without crowding the space. After the incident, company officers should debrief the crews after each cardiac arrest call, determine where you could improve, what, and what could be better. All personnel should review the process file, the CPR process file, to at least to review the dashboard to see, if CPR was done appropriately within the right parameters, critique any problems that might have come. You could also fill in, sometimes there'll be some gaps, and because you've just done this, you can say, well, that was when we were having to move the patient or whatever. All right. I promised you I would show you at least the algorithms. They have improved them a wee bit. They've made this less a little bit less cumbersome, and they managed to put the adult algorithm on one page, which is pretty amazing considering where we used to be. So starting with start CPR, identify unresponsiveness and a probable cardiac arrest, unresponsive and no pulse. Start CPR, give oxygen, attach your monitor, defibrillator. Now, is the rhythm shockable, i.e., is it VFib or VTAC? They are basically saying administer a shock. Now, we will still, if the patient had been having adequate citizen CPR, we then would go immediately upon assigning the rhythm, we would do a shock. If the patient was unwitnessed and you're the first to start CPR, we still think that priming the pump helps. So I would do 2 minutes, one sequence of CPR. Then shock, CPR for 2 minutes again. The rhythm is shockable, shock again. At that point, they would give epinephrine. So you have 2 minutes, 2 minutes. So that's 4 minutes, and you give the first dose of epinephrine. Then CPR again. If the rhythm is shockable, shock, and then at that point, which is 6 minutes, give your first dose of amiodarone. If the patient cannot take amiodarone for some reason, then lidocaine would be acceptable. Now, breaking news, which also I can't entirely report because one of the other studies that we did with the ROC study is to go back and call out a time differential between giving amiodarone and lidocaine and placebo, and comparing and seeing if there was a difference between early amiodarone and late amiodarone. And surprise, surprise, there is indeed. And ROS, not only does ROSC improve with earlier amiodarone, but discharge from the hospital alive and neurologically intact also. So, and the point where we made the break for the study was 10 minutes. So anything any amiodarone that occurred before 10 minutes, or lidocaine before 10 minutes, and any any amiodarone or lidocaine that occurred after 10 minutes was the break point. And it was statistically significant improvement with earlier amiodarone. It's less or not statistically significant for lidocaine. So this may be like you say, this is not published data yet. This is off to the publisher, but I think it's reasonably significant. Now, for asystole PEA, so the rhythm is, you've started CPR, the rhythm is not shockable, and you have asystole PEA. We want epinephrine in at that moment. So you're talking maybe 2 minutes by the time you get there. I like to see the first dose of epinephrine in a patient with asystole PEA within 2 minutes of time. Then another 2 minutes of CPR. If the rhythm is shockable, you shock it. If the rhythm is not shockable, then you go ahead and do more CPR, and you repeat epinephrine every 3 to 5 minutes. All right, now I'm throwing up the other algorithm, which is much improved, which is the return of spontaneous circulation algorithm. So if you've read pain, return of spontaneous circulation, then there's the initial stabilization phase. And the initial stabilization phase, per your orders and per the new recommendation, is between 5 and 10 minutes. And so in that time, you were preparing to move the patient to the ambulance, or preparing to get underway. First thing to do is to manage the airway. Now, if you're during the days of COVID, now they would like to have an early early placement of an ET tube. And as you recall, I was very much in favor for early intubation before transport of if the patient wasn't waking up. Obviously, if you get early resuscitation and they start moving around and talking, and as they sometimes do, obviously we're not going to manage, we're not going to take their airway at that point. So, but in the days of COVID, if you're having good parameters with your ET tube, or with your iGel, I would maintain the iGel, except if you're going to be transporting the patient who's on a Lucas. Obviously you probably don't have return of spontaneous circulation at that point. If you're transporting a patient in VFib on the Lucas device, you really have to have an ET tube in that patient. So early placement of an endotracheal tube at the paramedic discretion. Manage respiratory parameters. Start 10 breaths per minute. Keep your SpO2 between 92 and 98. Your PaCO2 between 35 and 45. And then manage your hemodynamic parameters. In other words, maintain a systolic blood pressure. Systolic blood pressure over 90, or a mean arterial pressure of greater than 65. Same difference. So you may need to start pressor agents at that point. Now, obtain 12 lead EKG. We always do that. And that's to do two things: we notify the hospital that we're coming in with a post-cardiac arrest who's got ST segment changes or not. And it's also in other systems where they have more than one receiving hospital possible. It would inform the the paramedic as to which hospital to take the patient, because you need to take a patient likely to a place that has cardiac cath capability. But in our situation, we have one hospital to receive a post-cardiac arrest, and that's Southwest, which has that same capability. A study I just read this morning shows that there's about a 18% false positive rate when the EKG is obtained within 8 minutes of the of the return of spontaneous circulation. That's probably just due to global ischemia and problems with the heart, which hasn't been fully reperfused. And so, but it also probably explains the reasons why people go into rearrest, usually within the first 10 minutes after the initial return of spontaneous circulation, which is why we want to do all the stabilization stuff. So if you have a positive 12 lead in that initial 10-minute period, certainly report that to the hospital. It's going to inform them a little bit more acuity of this, and then they will, and then repeat the 12 lead, probably at 15 minutes or so, 15 or 20 minutes, so that we can get a comparison. You probably see some improvement of the 12 lead. So that's kind of the basics. So getting back to your principles of high performance CPR, EMT's own CPR, minimize interruptions in CPR at all times, ensure proper depth of compressions, ensure full chest recoil and decompression, ensure proper chest compression rate of 100 to 120 a minute, rotate compressors, rotate compressors, rotate compressors, hover hands over the chest during shock administration, be ready to compress as soon as the patient is cleared, iGel airway with ongoing CPR, place an IV or IO with ongoing CPR. IO is IV or IO should be above the diaphragm. Coordination and teamwork between EMTs and paramedics and the hospital staff. Here's your walk cares data that I promised you, the 2019 data period, which we obviously don't have 2020 yet. It'll take about another 2 months. Walk cares is a cardiac arrest registry to enhance survival cares, and that's the Washington version. It is occurring now nationwide in about 22 different states. All right, now you can see that the yellow line that's sort of gradually creeping upward is our linear survival, survive to discharge line. And you can see that that's drawn just, it sort of cuts along. I mean, we see a gradual increase. And you say, well, gee, how come we had some really big changes in like 2015, 2016? Well, you have to realize this is Clark County specific data. So the N, even though there was 271 cases in one year and 198 in another year and 255 in another year, there's not a statistically significant difference between the numbers and also then between the percentages. And so we are basically gradually improving, and the difference between 2016 of a 20% overall survive to discharge rate and the 2019 rate of 19% is not statistically significant, looking at because the numbers are different Overall numbers are different, but it does show a gradual. But it also shows what I like about this. It shows a consistency, and I had said that the Heart Association was upset because we'd had we seemed to plateaued since 2014. Nobody is seeming to get better or worse, and indeed we do appear to be at roughly the same level. But overall, a 19 to 20% survive to discharge rate is remarkable for the state of Washington. I mean, we're very consistent to them, and it's remarkable compared to the rest of the United States. Now, the Etstein survival, the Etstein rules are, they look at the patients that are the most likely to be predicted to survive, which means patients who have a witness arrest with citizen CPR, bystander CPR, with early application of an AED, with a shockable arrest, those and early defibrillation. Those are the ones that are the most likely, we would think, would have the most likely characteristics to survive. And our Etstein survival rate, which had dropped for some reason, no one can really say why, had dropped in 2017, is right back up to good levels at basically 50%. And surprisingly, the ones that had bystanders didn't do as, there's a slight difference. I don't think statistically significant because of the N number. Between the Etstein survival group and the non-Etstein group, which might, well, I mean, with the non-Etstein, with the bystanders group. So maybe our bystanders aren't doing as much good CPR. I think it's probably just a matter of luck. But it's very good numbers. Let's go to the next slide, Mark. We're among the best in the state. So hospital characteristic, about 35% of people in our county and in the state die in the emergency department. Around the country, it's 56%. I think that's a combination. I think that's the thing that they transport. A lot of places still transport all out of hospital cardiac arrest, whether they've had return to spontaneous circulation or not, to the hospital. We have in Washington and our county about 65% of the patients that we bring to the hospital are admitted to the hospital. Nationally, that's only 44%. So it goes to show they transport a lot of people without ROSC. Ours are almost all ROSC or recurring or recalcitrant VFib. Discharged alive, Clark and the state are right at 28%. Nationally at 16%. Discharged with good neurologic function, we're a little bit above the state. Nationally, discharged alive, but with good, only 13% with good neurologic function. Okay. Well, quickly on to protocol revisions for January 2020. As you know, we do protocol revisions twice a year. So a change in written reports and documentation, which may have some anxiety, but if you're concerned about it, you can talk to me. But we've decided, and we've run this by the fire chiefs as well. An approved EMS medical incident report, an MIR, electronic or handwritten, must be appropriately documented and filed for any call for EMS assistance resulting in patient contact within Clark County. regardless of patient transport. This will apply to all responding agencies, BLS and ALS, and will include public assist calls. I want your public assist calls treated as medical calls. And so I want an MIR on this, and I would like documentation of vital signs, etc. Make this a medical call. Statistically and in studies, many of the public assist calls, particularly the ones that are repetitive, are premonitory of significant medical issues for the patient. And many of these turn into actual transports then. Now, how do you define patient contact? And this is important if you're saying, well, do I really need to write a report? I didn't do much on the case. I just, help them put the patient onto the gurney or whatever it was. Patient contact occurs when a provider contacts, sees, hears a patient, even if other providers are on scene and are the primary. Treatments and evaluations provided while said provider is in contact with the patient shall be documented as per this. They shall be documented. So you can document it very simply. You said, this is what we were handling with this patient. I didn't, see for all the medications, see AMR's report, see Vancouver Fire's report, whatever. And, but, this is what I did with the patient, what I didn't do with the patient. It's still a medical contact that needs to be in an MIR. If you're using a written format, handwritten, the SOAP narrative charting is still the best way that allows us to follow things. It's a legal record and may be called in evidence. Now, if it's an electronic report, then follow the MPD approved documentation guidelines for that charting application. This is where I need in evaluating quality of care issues. We are trying to get more and more information from our electronic charting. Here's the trick with electronic charting. If you don't put it in the drop-down boxes, that's where we capture the data. Data is not captured from your narrative, and I love the narrative, but data is not captured from the narrative unless someone sits down and physically goes through it and captures that data. So if you put down your CO2 in the narrative, I can't capture it. If you write the LAM score or put the fast or be fast in the narrative, we can't capture that unless we pull your chart and look it over and read the narrative. So whenever you have, and so if you put your medications in the medication fields when you give them, and we capture that. If you put your medications like the second dose or second, for example, in cardiac chest pain, if you put one of your nitros in the medication list and the next nitro in the narrative, I can't find it, and the chart will be dropped out if the patient still has chest pain, and you should multiply document your chest pain things for the appropriate condition. Death in the field. Here's interesting for traumatic death. We've had a couple of traumatic deaths lately, in the last year, and we've made a couple of adjustments. And this is in keeping with the protocol that's consistent in Multnomah, Clackamas, and Washington counties as well. An unwitnessed traumatic arrest is almost uniformly fatal when EMS witnessed unwitnessed trauma arrest is almost uniformly fatal. EMS witnessed traumatic arrest may be due to severe hypovolemia, hypoxia, or tension pneumothorax, and you can try to manage that. Now, that's called a HAT resuscitation. Hypovolemia, control external bleeding, apply a pelvic binder or wrap if there's pelvic trauma suspected or known, administer 1,000 cc's of lactated ringers. Then the A is airway and oxygenation, ensure airway patency and effective oxygenation. And the T is tension pneumothorax. If indicated, perform bilateral needle chest decompression. That's a HAT resuscitation, and that would be for a witnessed, if you witness the arrest. So you arrive, the patient's severely injured, as you're getting them out of the rig or evaluating them, they arrest. Then you would go through a HAT resuscitation at that point. By and large, if they're unwitnessed at that time, they're almost uniformly dead. Now, so trauma patients who are pulsosynaptic on EMS arrival are considered dead in the field unless there are extenuating circumstances such as hypothermia, or if you think this is not due to trauma, it's due to a medical cause. For patients found in VFib or pulsus VTAC on EMS arrival, suspect a medical event. Most of your trauma arrest patients will arrest in a PEA or an asystole. So VFib or pulsus VTAC, think not trauma, medical. So this is particularly the kind of you find the slow speed sort of drive off the highway, bang into a tree at low speeds. That's probably a medical event. For patients who deteriorate to PEA or asystole on scene, begin CPR, do your HAT resuscitation. If ROSC is obtained, transport to trauma center. If ROSC is not achieved, declare the patient dead or contact online medical control for guidance. If the mechanism of injury is inconsistent with patient's condition, not severe enough to induce traumatic arrest, consider primary medical cause. So we've reiterated it a couple times if you didn't catch it in the first. General housekeeping things. Triage criteria. Okay, for non-life-threatening injury or illness, the preference is for the closest, most appropriate facility. Now, you can go to a further appropriate hospital if that's the discretion of the patient, family, or the patient's physician. But this is for a non-life-threatening injury or illness. Life-threatening injuries or illness, transport to the closest appropriate facility. Now it says, unless diversion criteria are in fact. Diversion criteria are we divert for traumas to the trauma hospital. We divert for major stroke to the major stroke hospital. We divert STEMIs to the STEMI hospital. Then under diversion, because both hospitals are often totally jammed in the ED right now, mostly because of patients in the hospital, but they're jammed in the ED for a number of reasons. It occurs a little bit more commonly at Legacy, but it has been occurring at Peace Health Southwest. If Peace Health or Legacy are on diversion, generally it'll be the destination hospital will be the other Clark County hospital. So now, unless this was, say, a trauma entry and Peace Health says we are on divert, we've got 3 active traumas in here right now, we need you to divert. You would divert then to Legacy Emmanuel for as the diversion hospital. But if you have someone who you think has pneumonia, is not life-threatening, and Peace Health were on diversion, then you would divert to Legacy. Now, if both hospitals simultaneously go on divert, which they sometimes do, then there's no divert, and you just go to the closest, most appropriate hospital for that patient, either Legacy or Salmon Creek. We are not diverting patients out of Clark County who are critical or even uncritical, because Portland will be jammed at that point too. Now, a couple of general housekeeping, very simple. This is the very last thing, I think. Pain control facilitation. We have removed Versed from that, and Versed was really only in pain control facilitation to be used for when you thought there was muscle spasm associated with the cause of this pain. So we have unfortunately had too many patients be so somnolent upon receiving both fentanyl and Versed that they had to be intubated in the emergency department. This is called conscious sedation, and this is not something we do on that. So we have taken the Versed out. You still have ketamine as augmentation for pain. We still have Zofran for nausea and vomiting as needed for pain control facility. It's really not facilitating the pain, it's just taking away their nausea, which definitely helps them. We have changed our trauma entry a little bit because we're now using the Pulsera full-time for trauma entry. The trauma entry would meet your criteria for being what you used to describe as a full trauma or a modified trauma. So it's any trauma entry criteria. You're coming in code 3 with that patient because you believe, even if it's paramedic discretion, that patient has a condition that warrants early evaluation in a trauma center. And instead of requesting either modified or full trauma that is not part of the Pulsera, all you do is put in the criteria that you use in the Pulsera, put in the criteria that you're using to enter this person into the trauma system. So if it's not a trauma system entry, this patient is not coming in code 3, and you don't, they're just a normal patient who had maybe a fender bender and a minor, they're complaining of a little neck pain. You've got them in a C-collar, but you're not entering them into the trauma system. All right. That's, I think, concludes this. So any thoughts or questions? I haven't been watching the chat. I've left that up to Mark. This has been recorded, so it's available for everybody else to watch, and then because it's got a because it's our normal PCEP, this will be a required thing to be watched by all your crews.
Hey, Dr. Whitwer, I have a question on the documentation protocol.
Yep.
So with the documentation protocol, for example, if AMR is on scene first and they're providing patient treatment and fire arrives and only assists them like loading the patient or helping with the stretcher or
Right.
and literally has no patient contact, how do you want that documented?
How did they not touch the patient if they helped to load?
I understand the gray area there. I'm
The
just talking about
the argument is so do this as an EMS call, not as a I mean, just put it as an EMS call. Put in the minimal information, but you actually had patient contact, and you definitely know what the patient is being treated for. I mean, I'm assuming you're having conversation with the with people that this is not a this is not a this was an EMS call. You sort of document why you went on the call.
well, and I understand that, Doc, and it's being documented in the fire report as, you know, as an EMS call and assist another agency. So it's being captured in the NFIRS data.
But that's not
And then
that's not being captured in the walk cares data or anything like that.
well, it is with AMR's chart for this scenario.
Yeah, that's not. But what walk cares is, you know, we're reporting all EMS agency calls to the, you know. So it should be documented in the chart. If you had minimal, you know, and I'm assuming that they have some conversation and that they're agreeing with the um, agreeing with what the AMR paramedic is telling them.
Okay. Well, and I'm just concerned that
It can be minimal, but it has, you know, you need to document that is patient contact.
right. And I understand the minimal part, but unfortunately, like with ESO, it's not with the EHR side of that. It's not just a minimal piece. I mean, there's still all the drop downs that provider is going to have to go through and try to figure out an answer for when they didn't provide any patient care. They literally were just assist another agency of just providing manpower to get the patient to the gurney. I totally agree with you, Doc, if they're, you know, providing patient care and they're documenting as that provider what patient care they provided. But if all they're doing is literally just providing manpower to assist AMR to move that patient and have not had any true patient treatment contact, I think it's going to be hard for them to truthfully fill out the ESO EHR.
Well, let's have a conversation offline on that one.
Okay.
Dr. Whitwer, one of the questions that popped up in here was, do Lyft assists require a refusal?
Yep.
And I would think as a general rule that yes, a Lyft assist would require a refusal. And simply, you know, it's going to be interesting. I know that Dr. Mock, when talking about or during his documentation lecture, which was a few months ago, spoke directly to this and a specific study, I believe it was out of New Mexico, where it was a pretty significant percentage of patients that required medical care after a quote Lyft assist call. So yeah, I think that certainly sounds reasonable that a refusal needs to be at least discussed and documented.
Yeah, I would do that. That's a safety factor for the crew too, particularly if you find some abnormalities in the patient, whether it's, you know, in vital signs and documentation, that you think, well, I mean, we have had. I can point to a couple of Lyft assists on the last. They actually weren't. It was argument whether it was really a Lyft assist, but the patient had the patient was on the floor, and the husband called because he couldn't get her up, and she refused anything and said she had just fallen down. Well, we went back, a day later, and she'd had a C-spine fracture, and it was a darn good thing to have a documentation of a refusal.
So the next question is, can non-paramedic providers, i.e. EMTs, write refusals or have the refusal or document the refusal?
Depends on the case. The answer is yes, but it depends on the situation. If you have a paramedic there, you want the highest level to do that. Now, if this is a BLS call, you don't have anybody there, or it's always safest to have whoever does the evaluation could document. So if a BLS person does the documentation, then they could also sign the refusal. But generally speaking, we require the highest level of person present to do that. So, and generally speaking, almost nobody gets just a BLS response in this county. Now, if the paramedic
Did we lose you?
If the paramedic has evaluated the patient and determined that they are not an ALS patient, and that or that they can document that, or that they can, or that they're going to refuse, and he's recommended something, then the medic has to get the documentation. Refusals are the most medical legally challenging things for EMS. EMS almost never loses a suit or never goes to court on anything except leaving a patient at the scene. And it all depends on the documentation. Now, we've had in the past one significant case, more than one, but we had a significant case where both paramedics and fire BLS were at the scene. Transport paramedic evaluated the patient, determined that they probably did not have any major medical problem. It was a chest pain complaint, which had resolved. 12 lead had been done. It was inconclusive. Patient said, I feel better. I don't want to go to the hospital. I'm not going to go to the hospital. His wife was there. She heard him say that. Paramedic said, okay. And he said he had the fire BLS document the refusal. Patient, needless to say, case didn't turn out well when the patient had a cardiac arrest later on. That was a very sticky wicket for quite a long time, and it's basically, could have been solved by appropriate documentation of refusal.
We're getting a couple, some more questions on here that I think need to be answered administratively, and sure, I don't think would be of use to discuss right now, which actually both of those questions we can talk about at QA next time.
Okay.
Other than that, that's it.
All right. Well, thank you for your attention, and you can send any questions into the office too, and we'll answer it. And I'm just going to encourage all of you, if you haven't already got your vaccination, to get your vaccination. And if you're going for your second shot, we do recommend that you take prophylactically take some either ibuprofen or acetaminophen before the shot, and then 6 hours or so after the shot, and you probably minimize any. We are having, as predicted, more reactions to the second dose. I'm looking forward to it myself in a week or so. We're trying to get as many of our 1A EMS and first responders vaccinated as possible. It's the only way we're going to get the system back toward normal, is getting as much vaccination as possible out there. We will continue to provide Q&A on the vaccine. We've done it twice now. I think we'll probably not do it this week because of the PCEP, but we'll probably have another session next week. I've got right now about 60% acceptance of vaccination in the EMS crews. So with that, have a good other half of your month. Dr. Gadbois will be doing case reviews again on the last Tuesday of the month, I believe. So thank you.